Okay. Assalamu alaikum, everyone. My name is Nawaal Saleem. I'm a second year medical student, and today I will be talking about the brachial plexus. After we talk about the brachial plexus, we're going to talk about the upper limb nerve injuries. So there's two parts, so you have to stay focused, okay? Because brachial plexus is not something that you can just memorize. You have to understand it properly for you to actually remember all the innervations and the muscles. Okay, so focus. Let's start with the objectives. Describe the brachial plexus, identify the roots, trunks, divisions, cords, and branches. Describe the major branches of the brachial plexus, and then describe dermatomes and reflexes of the upper limb. Now, the dermatomes and the reflexes are it's like a small objective, so don't worry about that. For the clinical cases, we have injury to the long thoracic nerve. We have four types of humerus fractures and the affected nerves. And then we have injury of the individual roots and the reflexes that are associated. Okay, so let's move into the anatomy. This is the spinal cord, okay? And this is it's a long spinal cord. And here we can see the cervical section, we can see the thoracic section, we can see the lumbar, the green part, and then we can see the sacral. So what we're concerned about here is the cervical section, okay? Now, we have 12 cranial nerve pairs. What does that mean? That means in the head over here, we have 12 cranial nerves coming out from this side and 12 coming out from this side. So we have 12 pairs. Same for the spinal nerves. So if you have 31 spinal nerves coming out from, for example, the right side, then you have another 31 coming out from the left side. That's why it's called a pair. We will focus on the 8 cervical pairs over here. Now, the upper four, C1 to C4, form the cervical plexus and supply the neck. And the lower four, which is C4 to C8, and then you also add T1, these will form the brachial plexus and supply the upper limb. I hope that is clear. Then we move on to another diagram. So this is, again, the spine, okay? We have C1, this is the C1 cervical vertebra. This is the second one, so this is C2, this is C3, this is C4, this is C5. This is important, okay? Then this is C6, C7, and that is where it stops. So we have 7 cervical vertebra, okay? And then this is T1. This is a T1 vertebra. Now we move on to the 8 cervical nerves, okay? So we have a C1 cervical nerve, we have a C2 cervical nerve, then we have a C3 and a C4, and then that is where things start to get interesting because if this is C5 vertebra, then the cervical nerve is coming right from above the vertebra. Okay, so you have C6 and C7, and then C8 is coming out from below the C7 vertebra. And then for T1, you have the T1 T1 thoracic nerve coming out. So in total, we're going to focus on these 5 nerves. So C5, C6, C7, C8, and T. Now, what is a plexus? We keep talking about the cervical plexus and the brachial plexus, but what is a plexus? This diagram I think you've seen before. This is a section of the spinal cord, okay? This is the anterior, and this is the posterior, okay? Anterior meaning ventral, and posterior is dorsal, okay? So the ventral root comes out from the front, and it goes here, okay? We can see that. The dorsal root is going to come out from the back, woo, and it's going to come here. These two roots are going to join over here and they're going to give you the spinal trunk. Okay, so this area over here is called the spinal trunk, which is made up from the dorsal root and the ventral roots. Now, this spinal trunk is going to split. It's going to give you the dorsal ramus and it's going to give you the ventral ramus. This is for each level. For example, if you have, I'll move this away. Okay, there we go. Yeah, so the spinal trunk splits into the dorsal ramus and the ventral ramus, and this is for each level. So if this is C5, for example, then this over here is going to be the C5 ventral ramus. If this is, for example, C6, then this is going to be the C6 ventral ramus, and so on and so forth. Moving on to this picture. Now this picture over here, this whole thing is the same as this thing, okay, but it's like more obvious here. credits to the noted anatomist. Here you can watch the video. The video is very nice. Okay, so we have C5, we have C6, and then we have C7. Okay, from what we can see the diagram. This part coming out from the front is called the ventral root. And from the back, you have the dorsal roots. So the ventral root and the dorsal root are going to join over here, you can see. They're going to join here and give you the spinal nerve trunk. Okay. Now the spinal nerve trunk, see, is going to divide into two again. It's going to give you the dorsal ramus and it's going to give you the ventral ramus. If you move on to this diagram over here, you have the spinal nerve trunk, right? It's going to divide into the dorsal ramus and the ventral ramus. We are concerned about the ventral ramus here because this ventral ramus is actually the root of the brachial plexus. Now let's not get confused. If this is C5, then the C5 ventral ramus is equal to the C5 root of the brachial plexus. So if this was, for example, C7, okay, then this ventral ramus of C7 would come out. Let me just erase that to make it more obvious. Yeah. So if this was C7, the C7 ventral ramus is going to come out and it becomes the C7 roots. Okay. And that is going to be the case for each of these spinal segments from C5, C6, C7, C8, and C1. All these ventral rami are actually the roots of the brachial plexus. Okay. Hope that makes sense. So the definition of the brachial plexus is that it is formed from the ventral rami of the spinal nerve C5 to T1 to supply the upper extremities. Now the anatomy. Okay. Now let's look at this diagram over here. What we can see here are these two red things. These are the muscles. So this is the anterior scalene muscle, and this is the middle scalene muscle. Okay. And over here we can see the first rib. Okay, this is the first rib. So we can see there's like a little triangle that we can form. Okay. And the roots of the brachial plexus basically lie in this triangle. Okay, it's called the scalene triangle because a scalene is basically like a triangle with sides that are not equal. So none of these sides are equal. So the anterior scalene muscle is anterior, the middle scalene muscle is posterior, and then inferiorly you have the first rib. This triangle, you have the brachial plexus, and from here you have the subclavian artery also coming out. Now, what is the relevance of this? Why are we talking about this? First of all, if you want to give local anesthesia. So we all know that the brachial plexus basically supplies the whole of the arm. Okay, so it supplies the arm, it supplies the forearm, it supplies the hand and the fingers. If you want to block pain in any of these parts, we're just going to block brachial plexus at the top. It's going to like remove the pain sensation from the whole arm. So when you give, for example, a lidocaine injection, so you're going to block all the pain, right? That is the clinical relevance. That is local anesthesia. Another thing is thoracic outlet syndrome. Now, this is kind of important because if, for example, there is congenital cervical rib, okay, it is going to compress the brachial plexus over here at this very location, okay? And that is, again, going to cause numbness and tingling in the arm. If, for example, there's a car accident, God forbid, and the brachial plexus is again compressed, then it is also going to cause numbness and tingling. And if somebody has repetitive movements, for example, an athlete who's practicing badminton, okay, these movements are going to cause, for example, hypertrophy of the muscle or something like that. And that is, again, going to compress this brachial plexus. So this location is very, very important. Now, we move on to the main part. We have the brachial plexus, okay? And it is comprised of 5 roots, 3 trunks, 6 divisions, 3 cords, and many branches, okay? Now you need to know these like your last name, or actually your first name. So Robert Taylor drinks cold beer. So roots, trunks, divisions, cords, and branches, okay? This is a very nice diagram. I got this from Gray's Atlas of Anatomy. If you guys check that out, it has like very nice muscle diagrams too. Anyways, let's talk about the roots. Now, branches can come out from anywhere, okay? They don't have to be at the end. They can be anywhere. So they can be from the roots, they can be from the trunks, not the divisions, maybe from the chords, and so on. Okay, so we have C5, we have C6, we have C7, we have C8, and C1. I hope that this is ingrained into your mind. Then we have the branches. If we look at the root here, this is C5, it's going down, and whoa, it's giving off some branches. So we can see one branch, we can see another branch, we can see another branch. So there's 3 branches here, okay? We're not going to talk about contribution to the phrenic nerve, that's not important. But what is important is the dorsal scapular nerve. Now, this supplies the rhomboid major and the minor, and it also supplies the levator scapula. This is pretty straightforward. It elevates the scapula. And then we see this thingy going down, right? So as we follow it, I'm going to follow it down, okay? And whoa, it's going down. This is the long thoracic nerve, okay? But as we can see, it also has contributions from the 6th root and from the 7th root, okay? So C6 plus 7 plus 8 is going to give you the long thoracic nerve. And that supplies the serratus anterior. Now, serratus anterior is going to hold the scapula against the thoracic wall. So if you have a scapula at the back, not if, you do have a scapula, that scapula is going to be held against your back by this muscle. So God forbid this muscle gets paralyzed. Your scapula will go out and it will look like you have a wing at the back, which we will talk about in a bit. Okay. Again, branches from roots. So we have the dorsal scapular nerve from C5, and we have the long thoracic nerve from C5, C6, and C7. So it's going down at the radial aspect. Okay. Now, sorry, the lateral aspect. Now we have branches from roots. Again, we talked about this. The dorsal scapular nerve supplies the rhombus major, minor, levator scapula, and the long thoracic nerve supplies the serratus anterior. Okay. This is a visual. So dorsal scapular nerve, C5, rhomboid minor and rhomboid major. Okay, these 2 muscles. And also you can see this. This is the levator scapula. So for example, if this thing contracts, it is going to pull the scapula upwards. It's going to elevate the scapula. Okay. Then we have the long thoracic nerve. As I just explained, if it is paralyzed, the serratus anterior muscle is paralyzed, it's going to give you this winging of the scapula. Okay, then we move on to the trunks. We're done with the roots, not the trunks. So C5 and C6 will combine to give you the superior trunk. C7 is not combining with anything, it's just going straight. And then C8 will combine with T1, and that is going to give you the inferior trunk. So we have 1 and 2 and 3 trunks. Okay, now let's look at the branches. We follow along the superior trunk. We see 2 branches. We see this one, and then we see this one, right? So this is the suprascapular nerve, and this is the nerve to the subclavius. Now, supra for supra, so up, and subclavius means below the clavius, clavicle, not clavius. Okay. So this is a superior trunk, C5 root plus C6 root. So again, superior trunk, C5 and C6. Nerve to the subclavius, and also the suprascapular nerve, which supplies the supraspinatus and the infraspinatus. An easy trick is, of course, suprascapular, so that means supraspinatus and infraspinatus. Okay. Middle trunk has no branches. You can see there's no branches here. Inferior trunk also has no branches. So that's great. Moving on. I'm sure you guys took this in OSPE. If you didn't, you will. So this is our beautiful bone, okay? What is this bone? This is the scapular bone, okay? Now, above the spine of the scapula, you have the supraspinatus, and below the spine, you have the infraspinatus. And both of these are supplied by the suprascapular nerve, okay? We'll talk about these in a bit. Moving on. We have 6 divisions. This is easy. Now see, if we have 3 trunks, so we have 1 trunk, 2 trunk, and 3 trunk, right? Each of these trunks is going to give off 2 divisions. It's going to give off an anterior, and it's going to give off a posterior. So 3 times 2 is 6. So we have 6 divisions. So superior, anterior, and then posterior. Middle is going to give anterior, and then posterior, and then inferior is going to give off anterior and posterior. Okay, pretty straightforward. And there are no branches. If you look at in this area, you don't see any branches. So that's great. Moving on to the chords. Now, this is kind of difficult. Actually, yeah, it is difficult. So what you have to see is that these two anterior branches. So the superior trunk and the middle trunk. Now focus on the anterior branches. So the anterior branch of the superior trunk is going to go straight, and the anterior branch of the middle trunk is going to go and join it. It's going to give you the lateral cord. Okay? Now move on to this one, the inferior. You follow it along, you see that the anterior becomes the medial cord. Okay? That's very straightforward. And now this posterior cord over here, okay? That's very simple. It's going to have a branch from each of the trunks. So the posterior division, the posterior division, and the posterior division. So these three posterior divisions are going to combine to give you the posterior cord. Okay, I might have been fast, but let's go over it one more time. The anterior divisions of the superior and middle trunk form the lateral cord. So anterior division, also anterior division, form the lateral cord. Then, the anterior division of the inferior trunk continues on to form the medial cord. So inferior, trunk, and then the anterior division, and then that forms the medial cord. All the posterior divisions form the posterior cord. So we know that each of these trunks has a posterior division. So 1, 2, 3. Those join to give you the posterior cord. So in total, 2, 1, and 3, we get 6 divisions, and that forms 3 cords. Okay? Now, what we want to focus on here is, let me just erase this real quick. It's a little messy. Okay, so what we want to talk about is the relevance of the anterior divisions and the posterior divisions. Okay, so the anterior divisions supply the flexor compartments. Okay, the posterior cord, which is made up of the posterior division, supplies the extensors. Now, what that means is that you have one anterior, you have the second anterior, right? These are joined to give you the lateral cord. That means since this is made up of anteriors, it is only going to supply the flexor compartments, okay? And here you can see the medial cord is also only made of the anterior division, right? So it's also going to supply only flexors, okay? Posterior, however, okay, this is like ganging up. It's made up of posterior 1, 2, and 3. And so it is only going to supply extensors, okay? Moving on, we have the lateral cord. We're going to look at each cord individually, okay? So let's focus here. We have the lateral cord, okay? This is the lateral cord. If we draw like a square around it, we can see that it gives off one branch over here. This is the lateral pectoral nerve, okay? Now, the lateral pectoral nerve is made up of C5, C6, and C7. So how did that happen? Okay, let's trace back. Now, lateral pectoral nerve is coming from the lateral cord. The lateral cord is made up of 2 anterior divisions, and each of these anterior divisions is coming from the superior and the middle trunk, and the superior and middle trunks are coming from C5, C6, and C7. Okay? What is going to help is that if you have like a notebook or your iPad next to you and you you start drawing as well, because you won't really understand from listening, you have to draw as well. Okay, so after I explain this, I'm going to draw as well. Now, the lateral pectoral nerve is going to supply the pectoralis major, which is basically your pecs. So everybody knows what pecs are. Then we have the musculocutaneous nerve. Okay, now this lateral cord is going to go on, it's going to become the musculocutaneous nerve. We can see that. And it is also going to become this thingy over here. Now, what is this thingy? Okay, this is the lateral root of the median nerve. Now, as we can see here, okay, this thing over here, this is the median nerve. And it is basically a formation of 2 divisions, sort of, okay, like 2 branches or something, whatever you want to call it. So there's 1 and there's 2. So the median nerve is made up of the lateral root of the median nerve. The median nerve is made up of the cord. Okay, so one of the cord is going to come down and it's forming the median nerve. Okay, this is a little bit complicated. Okay, so one more time. Lateral will give off the lateral pectoral nerve. It's going to give up the musculocutaneous, and it's going to form the lateral root of the median nerve. Okay, so 1, 2, and 3. The musculocutaneous nerve is basically, it's a terminal nerve. You can see here it's a terminal nerve, and it supplies the flexors of the arm and skin of the lateral forearm. We shall come to that. Then we have the medial cord. Okay. So we're going to move on from lateral to medial cord. Now, if I draw a square around the medial cord like that, okay, I can see 1, 2, and 3 branches, right? So the medial pectoral nerve is right over here, okay, and it is going to supply the pectoralis major and the pectoralis minor. Now, we just talked about the pectoralis major, right? So over here, we had the lateral pectoral nerve, which supplied the pectoralis major. And the medial pectoral nerve also supplies the pectoralis major. So that means that this pectoralis major has a dual nerve supply, okay? And the pectoralis minor over here is just the medial pectoral nerve, okay? And then we have the ulnar nerve. So we move on, and we see that it goes to become the ulnar nerve. This is a terminal branch, okay? And it also forms the medial roots of the median nerve. Same thing. It goes up and it joins in to form the median nerve. Okay? Now let's talk about these two branches. We have the medial cutaneous nerve of the arm and the medial cutaneous nerve of the forearm. What that means is basically medial, meaning medial cord, cutaneous, meaning skin, and then arm. So it's going to supply the skin of the arm medially. Okay? And medial cutaneous nerve of forearm means it's going to supply the skin on the medial forearm. Now notice everything, all the numbers here are C8 and T1 because the medial cord comes from the anterior division of the inferior trunk, which is basically C8 and T1. I hope that is clear. Let me just clean this up. Okay. Now we move on to the posterior cord. Okay. This is the last cord. Now, if we draw another square, I love drawing squares. It's very nice. Okay. Now the posterior cord is going to give off a lot of branches, so bear with me. We have number 1, we have number 2, we have number 3, we have number 4, and then we have this huge radial nerve. Okay, so that's number 5. So number 1 is the superior subscapular nerve, okay, or also called the upper subscapular nerve, and it supplies the subscapularis. Then you have the thoracodorsal nerve over here, okay? This is the thoracodorsal. It's going to supply the latissimus dorsi, and then you have the inferior subscapular nerve, also called the lower subscapular nerve, and that is going to supply the subscapularis and the teres major. Okay. Now let's look at the numbers. We can see here that the posterior cord is a union of posterior divisions of all 3 trunks, so basically all 5 roots. So C5 to T1. Now look here, this is the posterior cord. Okay, let's erase this thing first. Yeah. So this is the posterior cord. It is getting divisions from the superior trunk, from the middle trunk over here, and from the inferior trunk over here. And these 3 are basically coming from 5 roots. So we have C5 to T1. And thus all these 3 nerves over here have a gradient. So C5 to C6 for upper subscapular, C6, C7, C8 for thoracodorsal, and C6 to C7 for lower subscapular. Okay, and this axillary nerve over here is a terminal nerve, and the radial nerve is also a terminal nerve. Now the radial nerve over here is very, very important. So we will come back to it. Of course we will. This is the biggest branch of the whole brachial plexus. Moving on. Again, rotator cuff muscles. So we talked about supraspinatus. We talked about infraspinatus. Now think about where we talked about these 2 muscles. We talked about them when we were talking about the suprascapular nerve, right? Now, subscapularis, we just talked about this. This is by the upper subscapular nerve and the lower subscapular nerve, okay? And the teres minor we'll come back to later. And also we have teres major and latissimus dorsi, okay? Now, if you remember, teres major was also supplied by the lower subscapular nerve along with the subscapularis, and latissimus dorsi was the thoracodorsal or middle subscapular nerve. Okay, these are tongue twisters, but you will get the hang of them. Okay, just go over all this a few times. Now, if you look at this diagram, latissimus dorsi is this huge muscle. Huge. It basically extends abducts and internally rotates the arm, okay? And the teres major is this muscle right over here. Has the same functions as the latissimus dorsi, okay? Let me move on. The three chords in relation to the axillary artery. So what this means is that we have three chords, right? Three. We have the medial cord, we have the lateral cord, and then we have the posterior cord. So basically, medial to what or posterior to what? What is the relation here, okay? So we're talking about lateral or medial or posterior to the axillary artery, okay? This is what is in the middle. So if you look at this diagram, I'm sorry, the pixels are really bad, but this is from Vlad's slides. You can look at it there. This is the axillary artery, okay? You can see that this is the medial cord, this yellow thingy, and this is the lateral cord over here. And behind this axillary artery, behind this red thingy, you will find the posterior cord, okay? And that is what is very important here, because, I don't know, might come in the OSPE. Could be. So again, axillary artery, medial cord, and the lateral cord. And you can see later on it becomes like an M, so we'll come back to that. Moving on. Practice drawing the brachial plexus with me. So basically, I'm sure that everybody is watching the recording. Right now, I don't think there's anyone in the meeting, but we're gonna draw this. You can skip this if you want, but it would be very, very helpful if you draw with me instead of just staring and watching me struggle, okay? So I might struggle, that's okay, because we all struggle. Now, this is how we're gonna draw it, okay? And then I'm going to label it later. So we start with like two V's and then we extend the V's, something like this, okay? And then we make two. Okay, actually, we'll come back to that. Now let's label this first. We have C5, okay? We have C6, and then we have C7, we have C8, and then we have T1, okay? These are the roots, okay? So Robert Taylor drinks cold beer. So Robert Taylor, what's next? We have trunks. So again, we have 5 roots, and then we have 3 trunks. This is the superior trunk, this is the middle trunk, and this is the inferior trunk. Okay. Now we come to the hard part. We have divisions, right? Robert Taylor drinks, so D. So I'm going to draw the posterior division first, okay? So I'm going to go ahead and extend this a bit. I'm going to take one branch from here, sorry, one division from here. And I'm going to take one division from here, okay? Just like that. And that is going to form my posterior cord later, okay? And then we want to draw the anteriors. Take another color, I'm going to take green for the anteriors. And how do I make this go back? Now, whoop, anterior. Now we want this anterior to join that anterior at the top. So we just join that up like that, okay? Extend that. And then this one is not joining with anything. Just go straight ahead, okay? Now let's label that. So the green ones are the anterior divisions. And then also, this is also the anterior division. And this is also the anterior division, okay? Now we shall label the posterior ones. This is the posterior division of this, what is this? The superior trunk, the posterior division of the middle trunk, and then the posterior division of the inferior trunk, okay? So let's count the divisions to make sure that we didn't miss any. 1, 2, 3, 4, 5, 6. That's great. We're good. Then we move on to the chords, okay? I'm gonna go back to my blue color actually, like that. Now, we have, this is gonna be the lateral cord. Now, why is this a lateral cord? Because look, C5, C6, okay? This is the one at the back, posterior cord. How do you want to identify the posterior cord is that you go back, you trace back, and you see 1, 2, and 3 divisions. So that's gonna mean that you have the posterior cord. And then you have the medial cord over here. Yippee! Okay? And now we want to make finally the branches. okay? So let's start with the posterior cord. Again, this is the easiest. So I'm going to use red. You know why? Because the posterior cord doesn't join with anything. It just goes straight ahead like that. And it forms the radial nerve. Okay. And then for the others, however, it's a different story. I'm going to use brown. Now, what happens is that we want to form the median nerve. Remember, the median nerve is formed by the lateral and the medial cords joining together. So we have this coming down and then this going up like that, and that forms the median nerve. So this is the median nerve. And now you extend the lateral cord straight ahead. This is the musculocutaneous, okay? And then you extend the median cord straight ahead, and then you get the ulnar nerve. Voila, you have drawn the brachial plexus. Congratulations. Now we shall label. Okay, I'm going to use black. Now let's start with let's make it easier. Okay, so we're gonna divide this into sections. We have the roots. Okay, so this is a very rough division. The roots, and then we have the trunks, which are just very nice, 3 straight lines. No need to worry. And then we have this messy area, which are obviously the trunks. So, sorry, not the trunks, the divisions. Okay, I messed this up too. So Robert Taylor drinks cold beer. And the last part are the branches. You had to be there. Okay. So what branches do we have that are coming out from the roots? We have the dorsal scapular nerve. So that's one. We also have the long thoracic nerve, which is very long. Okay. So it starts from C5. Okay. So just like draw like a long line down. It is joined by 6 and it is also joined by 7. Okay, so this is the long thoracic nerve. And then we move on to the trunks. And the trunks, we had, again, 2 branches that we discussed, right? We had the suprascapular nerve, and then we had the nerve to the subclavius. Okay, so this is the supra. And this is the nerve to the subclavius. I hope you can read cursive. Okay. The divisions, thankfully, are messy enough. They don't need any more branches. Okay. The cords now, we talk about the lateral cord. So it's going to give off the lateral pectoral nerve. Okay. So remember, LP, lateral pectoral nerve. Okay. For the medial cord, we had the medial pectoral nerve. Straightforward, yeah? So medial pectoral nerve. Okay. And then for the medial, we also had 2 more branches. Recall we had 1 and 2. So this is the medial cutaneous nerve of the arm. Okay. And this is the medial cutaneous nerve of the forearm. For the lateral, we didn't have any more branches in the cords. For the posterior, however, again, we have 5, remember? So we have 1, the first one, and then we have the second one, and then we have the third one. Okay. This is the superior subscapularis, or the superior subscapular nerve. This is the medial subscapular nerve, and this is the inferior subscapular nerve. Okay. So basically the middle subscapular nerve is also the thoracodorsal nerve. It's the same thing. Just go back up if you're getting confused. Okay, so look here. In the posterior, you have the superior subscapular, you have the thoracodorsal, and then you have the inferior subscapular. Okay. After those, you have the simple axillary. Okay. And then you have this major branch. This is the radial nerve. Whoa. Okay, so how you can remember this is that posterior cord is basically invincible. It supplies the extensor compartments, SSS, PPP, and then the radial nerve, and also the axillary zone here. Okay. Then you have the branches. Now, from the lateral cord, you have the musculocutaneous branch, and you also have this little roots going to the median nerve. Okay. And then from the medial cord, you have the ulnar, and then you have this little medial root to the median nerve. Okay. Now this is just a drawing session. You can do it on your own. You don't have to listen to me, but this might help. Question. What are the terminal branches of the brachial plexus and from which cords do they arise? Okay, so pause and answer. You have musculocutaneous from the lateral cord, axillary from the posterior cord, radial also from the posterior cord, median is from the lateral and medial cords, and then you have the ulnar from the medial cord. Yippee! That's great. More questions. Okay, I will read them out. What muscles does the dorsal scapular nerve C5 supply? Okay, so which of these is the options? Where does the long thoracic nerve lie? And what muscles does the thoracodorsal nerve supply? These are your answers. Okay. Now, let's move on to the individual nerves and what they supply. Now, as we recall, the musculocutaneous nerve C5 to C7 is from the lateral cord. So if you look at the arm here, there's an M forming, right? I want to emphasize on this actually. So let's go back for a sec. If you look here, let me erase this for a sec. Okay. Now I will choose a bright green. If you look here, we have an M forming. Look at that. That's an M, right? So over here, laterally, you have the musculocutaneous. Medially, you have the ulnar. And in the middle, the long M is the median nerve. Okay? Now, let's go back to the musculocutaneous. Right, so we see the same M here. So this is the lateral cord. M forms the musculocutaneous. The musculo, meaning motor to flexors. So the coracobrachialis, brachialis, and biceps. So these three muscles. And cutaneous, which is sensory to skin on the lateral forearm. So if you have the forearm, okay, you have laterally. This is the sensory supply of the musculocutaneous. Because the musculocutaneous continues as a lateral cutaneous nerve of the forearm. I mean, it's all in the name. You just have to memorize this. Moving on to the median nerve. Okay, this is a little bit too much on the slides, but we shall go through it. Okay, so we have the median nerve, which is from C5 to T1, so it's everything. Okay, all the roots. It has no branches in the arm, only in the forearm. So as you can see, there are no branches here, no branches. But in the forearm, there's a lot of branches, and also you can see in the hand. So articular branches to the elbow and the wrist. Wrist joints. It's not joints, it's joints. Okay. So basically what that means is that, let me just pull up the definition of that. Where is it? Okay. Basically what that means is that articular branches are basically to the joint capsule of the elbow and the wrist, and they give proprioceptive information to the brain. Okay, you will take this in neuro. Just know that there's articular branches to the elbow and the wrist joints. Now, motor to all forearm flexors plus pronator teres, and pronator quadratus. So all these flexors are supplied by the median nerve. So you have pronator teres, you have carpi radialis, you have palmaris longus, flexor digitorum superficialis and profundus, but only the radial parts. Okay, we'll come back to that. Flexor pollicis longus, pronator quadratus, and then you have all these thumb muscles. Okay, and the first and second lumbricals. Very important. Now, it is motor to all forearm flexors except for flexor carpi ulnaris. Ulnaris, it's in the name. It's going to be ulnar nerve. And the medial half of FDP, which is the flexor digitorum profundus. Okay, so these two things, these two flexors are not supplied by the median nerve. And then you have a recurrent branch, which goes to the thenar meaning thumb, and lumbricals 1 and 2. And then you have the palmar cutaneous branch to skin on the lateral part of the palm, including the 3.5 digits. Okay, what that means is that if you take out your palm, the sensory supply of the palm, so your thumb, your first index finger, and then your middle finger, are basically going to be supplied by the median nerve. Okay, so if you can see here, this is the palm. So you have the thumb, you have the index, you have the middle finger, and then this area is all supplied by the median nerve. Okay, and this little bit area, we'll come to that in a bit though. But remember this for now. I'm gonna change the pen color to okay, let's go with blue. Now, The ulnar nerve, C8 to T1. This is very, very easy. Why? Because it's the funny bone. It's also called the crazy bone. Oh, that's crazy. It's called the crazy bone and the funny bone. Okay, so this nerve is palpable to behind the medial epicondyle. So if you take your medial epicondyle, okay, you take your elbow, you feel for the medial epicondyle. Behind that, you will find the ulnar nerve. And if you like, sort of like, I guess, hit it, it's going to make you feel funny. That's why it's called the funny bone. Again, just like the median nerve, there are no branches in the arm. None. Okay. However, there are branches in the forearm and the hand. So we have articular branches to the elbow joints. Okay. We talked about this. For the median nerve, it was elbow and wrist. For here, it's only elbow. And then it is motor to flexor carpi ulnaris and medial half of FDP. Now, these were not supplied by the median nerve, but they are supplied by the ulnar nerve. So we have carpi ulnaris, and we have the medial half of the flexor digitorum profundus. So over here, ulnaris, and the ulnar portion of FDP. Now we move on to the deep branch. Okay, let's talk about the deep branch first. We have the hypothenar, which is basically below the pinky. Okay, so thenar is for the thumb, median nerve, and hypothenar is for the pinky, which is supplied by the ulnar nerve, the interossei. Now, the interossei are basically little tiny muscles in your hand that help with finger abduction and adduction, abduction and adduction. So you have pad and you have dab. So palmar interosseous is going to help with PAD, so palmar adduction. Dorsal interosseous, dab, so dorsal abduction. Okay, so pad, palmar adduction, and dorsal abduction. Now, this also supplies the lumbricals third and fourth. So over here, third and fourth lumbricals. Woohoo! Easy peasy. Now we move on to the innervation, the sensory innervation. Okay, so palmar cutaneous branch to the medial part of the palm and 1.5 fingers. Dorsal cutaneous branch to the posterior surface of the same 1.5 fingers. So basically, if you take your pinky, you take your ring finger, that sensory supply on both sides of the hand is supplied by the ulnar nerve. So on the palm, you have this area. On the dorsum of the hand, you have this area, okay? Except for this little part, which we will come back to later, but this is a general area, okay? When we talk about the axillary nerve, now recall, where does the axillary nerve come from? It comes from the posterior cord. That's right. So basically, this is C5 to C6. Now remember that the posterior cord has a spectrum. It goes from C5 to T1, but axillary nerve is from C5 to C6. Okay. It is motor to teres minor and the deltoid. This is teres minor here and deltoid here. Okay. And cutaneous branches to skin on lateral upper arm. So basically above the deltoid. So the deltoid is basically over here. And above that, the skin is upper lateral brachial cutaneous or axillary innervation. Easy peasy, hopefully. Now, this was teres minor and deltoid, right? So over here, we can see where's deltoid. This is deltoid. Okay, so this is huge muscle. Then we have the teres minor. Where is teres minor? Right there. So this is the teres minor. Okay, so both of these are supplied by the axillary nerve. You can read through the functions here. Then we have the radial nerve, C5 to T1. Now, if you recall, again, posterior cord was a whole spectrum, C5 to T1. And radial nerve is the biggest branch of the brachial plexus from the posterior cord, okay? So it's from C5 to T1. And since it is made up of posterior divisions, it is going to supply all the extensors, okay? So we have motor to the extensors. In the arm, you have triceps and you have the anconeus. For here, you have triceps, triceps, triceps. There's 3 triceps because if you look at the name, it's triceps, so 3 heads. So you have the lateral head, you have the long head, and the medial head, okay? Then you have the anconeus right here, okay? Then we have the deep branch. The deep branch is motor to the forearm extensors and continues as the posterior interosseous nerve after supinator. What that means is that the radial nerve gives off a deep branch, okay? And that is going to supply all these forearm extensors. So you have all of these, okay? And you have all of these are supplied by the deep branch. And the posterior interosseous nerve is after the supinator. So what this deep branch does is that it goes and then it pierces the supinator. And after it does that, it is called the pin or posterior interosseous nerve. And then we talk about the sensory innervation. So this is just something that you have to learn, unfortunately. Cutaneous branch and arm to skin of lateral lower arm. Okay. Over here, for the axillary nerve, it was cutaneous branch to skin on lateral upper arm, right? For radial, it's lateral lower arm. And then posterior cutaneous nerve of forearm to skin of posterior forearm and wrist. Okay, so basically, posterior forearm. So if you take your forearm, the posterior side, and the wrist. Okay, that makes sense because the extensors are also on the posterior side. And then superficial branch to skin on dorsum of hand. Okay, that also makes sense. 3.5 fingers. Now, this is a summary. Shall I go through it? I shall go through it. Okay. So we just talked about the radius. Okay, supplies the triceps, anconeus in the arm, extensors of the forearm, sensory skin on the lateral lower arm, posterior forearm and wrist, and also the dorsum hand skin, 3.5. Okay, which means like the lateral 3.5. Median, C5 to T1 again. All flexors of forearm except for 2. Okay. Now, you have all these flexors in the forearm, and that median nerve is supplying it. The 2 exceptions are flexor carpi ulnaris and the medial half of FDP, flexor digitorum profundus. And then you have thenar muscles, which are the thumb, and the 1 and 2 lumbricals. Then you have 3.5 lateral palmar sensory. Just look it up in the previous slides. For ulnar, you have C8 to T1. So those 2 flexors that were not supplied by the median are supplied here. So you have flexor carpi ulnaris, and you have the medial half of the FDP. Then you have the hypothenar, which is basically the pinky muscles, interossei, 3 and 4 lumbricals. Okay, and then 1.5 fingers, you have the sensory. So you have it on the medial side, on both sides of the hand. So on the palm and on the dorsum. For axillary, C5 to C6, teres minor and deltoid, and sensory skin on lateral upper arm. Muscular cutaneous, flexors of the arm, and lateral skin of the forearm. Whoa. These are the hands. Okay. As you can see, this is the palmar side, and this is the dorsal side. Okay. Now let's start with the ulnar. The ulnar is the easiest. Okay, so you can see here. On the palmar side, you have all the pinky and the palm area. You have half of the ring finger and the palm area. Okay. Opposite side. All the pinky and half of the ring finger. Okay. Then you have the median nerve. Over here, you can see that it supplies this half of the ring finger. Then you have the middle finger, and then you have the index finger, and then you have the thumb. So the palmar aspect of all of this, so 1, 2, 3, 3.5 digits, and the palm is by the median nerve. Okay? Now, the dorsal. Now, on the dorsum of the hands, laterally, you can see like there's a lot going on here. So the median nerve, which was orange, it also supplies up to the middle phalanx. So this is the middle phalanx, and also the middle phalanx. Okay, so for the index finger, the middle finger, and half of the ring finger, you have a median nerve innervation. However, from below the middle phalanx of the index of the middle finger and half of the ring finger and the dorsum of the thumb, and then this palm area, you have, what is this? The radial nerve. Okay. Okay. So we have ulnar. Okay. And then we have, let me just do that one more time just to make it very, very clear. You can skip this if you want, if you've already understood, but if you haven't, keep watching. Right. So let's use black. Now, you have ulnar. Okay? Both sides of the hand, medially. And then laterally, you have 2 innervations. You have the median nerve on the palmar side and a little bit of median on the dorsal side. And then the rest of the area that is not supplied by the median is supplied by the radial. that's pretty much it. Now, if you have a case where the lateral half of the ring finger is numb, okay? So if you have the ring finger and the lateral half, okay, over here, the lateral half of it is numb. So lateral is this side, by the way. That means that you have a median nerve injury. This is how you do the questions. Moving on to the humerus fractures. Okay, so there's basically 4 types of humerus fractures that you have to know. This is the humerus. This is the anterior view. Okay. Now, what we have here is the head. We have the greater tubercle. We have the lesser tubercle. And then we have the surgical neck. This is the neck of the humerus. Select a red. Okay. Now, if you have a fracture here, you are going to damage the axillary nerve. Okay. So the axillary nerve is damaged and the posterior circumflex artery. This is important. It came into OSPE last year. Very important. Next, midshaft fracture. So midshaft basically means the middle of the bone. You fracture that, you get a radial nerve injury, and you also get an injury of the profunda brachii artery. Okay. And then we have supracondylar fracture. Okay, so these are the condyles. You have the medial one, the lateral one, probably. So above that, you have the supracondylar area, right? Above the condyles. So over here. If you fracture that area, you're going to fracture this nerve, the median nerve, okay? And also the brachial artery. Then we move on to the fracture of the medial epicondyle. So medially, if you break like this little tiny piece, this is where the ulnar nerve is passing, and you're going to get a lesion of the ulnar nerve. I hope these are clear. I mean, this is just memorization, but please make sure to know all of it properly. This slide, I watched the recording, and Dr. Vlad said that just have to know that there is a spectrum here. Again, from the shoulder, you can see that it goes from C5 to the digits, which is C7, C8, and the hand, which is T1. So basically, as you move from the shoulder to the elbow, to the wrist, to the fingers, it goes from C5 to C6 to C7 to C8, and so on and so forth till T1. Okay, so basically, it's a spectrum. That's all you have to know. And dermatomes of the upper limb. Now, dermatomes are quite complicated sometimes for a lot of people, but what you have to do for this lecture is that you have to learn the definition and you have to know these 3 dermatomes. That's all. So dermatome is an area of skin innervated by one dorsal root ganglion. Okay, so C6 dorsal root ganglion innervates the thumb. C7 DRG innervates the middle finger, and for C8 it's the small finger or the pinky. And that's it. So we move on to the reflexes. Okay, this is so fun. Now, this is where you have injury of individual roots. Recall the roots were C5, C6, C7, C8, and T1. Okay. Now imagine you damage C5. Okay. Now, if you recall, the axillary nerve, which was coming out from the posterior cord, basically is innervated by C5 and C6. Okay. So if you damage C5, you're going to have a weakness when you test for deltoid. Okay. So deltoid is supplied by C5 and C6. So if you cut out one of these, you won't have full paralysis because it's still supplied by C6, but you will have weakness. Okay, so motor signs, weakness. And sensory loss is above the area of the deltoid. We talked about this. Then we talk about the level of the biceps brachii. Okay, so C6. So the biceps brachii is supplied by the musculocutaneous, which is C5 and C6. Okay, so again, you could have an absent reflex if the injury is severe, but mostly it's just a weak reflex because it is supplied by both of these, so C5 and C6. By the way, what would help is watching a video where you see like all of these being tested. That would make it much easier because it's a visual. For C7, we have triceps brachii. Again, this is innervated by the radial nerve, if you recall, and that is C6, C7, C8. So if you have a lesion of C7, for example, you're going to have a weak or an absent reflex. Okay? Because again, the the heads of the triceps are supplied by the different by the C6, C7, and C8. Okay. Let me just pull out where it says about. Okay, never mind. Just know that each of the heads is supplied by each of these. So C6, C7, and C8 supply individual heads of the triceps. Now, for C8, you have the interossei. Now, if you have a lesion at C8, you're going to lose abduction and adduction of the fingers. So no abduction, no adduction of the fingers. Okay? So this won't work. And you also have an associated Horner syndrome. Now, Horner syndrome only occurs if you have a disruption of preganglionic fibers of T1, okay, which basically means sympathetic fibers. It's a little bit complicated for you, but just know this fact, okay? Moving on to more reflexes. Okay. This is something that you have to learn. The bicipital reflex is C5, C6 by the musculocutaneous nerve, and the muscle tested here is, of course, the biceps. For triceps, it's C7 to C8. You have the radial nerve, and the muscle tested is the triceps. And then for the forearm, you have C5 to C6, innervated by the radial nerve, and the muscle tested here is the brachioradialis muscle. Okay, just learn that. And that concludes brachial plexus. Congratulations. If there's any questions, guys, please don't hesitate to email me or send me a message, okay? Now we shall move on to the second part. Excuse me. Rain. Hello, Ragat.
Yes.
I think I shall take a break.
Okay, sure.
I'm gonna go pray and I'll. Hey, hello everyone. Welcome back. So we will continue with upper limb nerve injuries. We've discussed the brachial plexus, we've discussed the roots and the trunks and the divisions and the branches, and now we're going to find out what happens if there are any injuries or lesions to any of these branches. So, objectives. Describe injuries of the roots and trunks of the brachial plexus. Describe injuries of the cords of the brachial plexus. Describe injuries of the individual nerves of the brachial plexus. And then for the clinical cases, we have the surgical neck, midshaft, supracondylar, and the medial epicondyle fracture that we already talked about in the previous section. What's new here is the carpal tunnel syndrome and the hamate bone fracture. Okay? Now, let's move on to the nerves that we have to know. So, first of all, we have to know the axillary nerve. Recall that the axillary nerve comes out from the posterior cord. So, if we have the cord here, this is the axillary nerve going out right there. Okay. Next, we have to know the musculocutaneous nerve. Now, recall this was a terminal branch of the lateral cord. So, look at the lateral cord here. It is going to give off the musculocutaneous nerve. The radial nerve is C5 to T1. It's huge, right? So it comes out from the posterior cord over here. So if you go ahead, straight ahead, you find the radial nerve, okay? And then you have the median nerve, which is C5 to T1 again. So it forms from the anastomosis, basically, of the lateral cord. So you have the lateral cord here and you have the medial cord here, okay? So it's going to give off 1 and 2 roots, and that is going to make the median nerve, okay? So let's clear this up. Right. Next, we have the ulnar nerve. Recall this was also a terminal branch. So you have the inferior trunk over here, you have the medial cord, and then that gives you the ulnar nerve right here. And then the long thoracic. This was a branch from the roots. So recall we have C5, C6, and C7. So C5, C6, and C7 right here is going to go down and give you the long thoracic nerve, okay? Then we have the suprascapular. Again, this was from the superior trunk. So you see this is the superior trunk, and then you get the suprascapular nerve. I hope that this is clear. Next, we move on to the pulses. We have the upper brachial palsy, okay? So injury of the upper roots C5 to C6 or the superior trunk. So if you see here, you have C5 and C6, and they join to make the superior trunk. So any of these three areas, if you injure C5, if you injure C6, or if you injure the superior trunk, you're going to get an Erb's palsy. This is due to the increase in angle between the neck and the shoulder. Now, what are the situations where this could happen? For example, if you have a person, he was painting a house, okay, and he was on the ladder. If he falls from this ladder, okay, and he falls into this position, now there's an increased angle between his neck and his shoulder, right? So that is going to stretch or tear the upper brachial plexus. So C5 and C6 will be damaged. Or during birth, if you pull the baby's head out, you're going to increase the angle between the head and the neck. And babies, they're very fragile too. So that is going to cause, again, an upper brachial palsy. Or a motorbike accident that will cause you to fall into the same position as shown will cause the palsy. So moving on, Erb's palsy is basically short for Erb Duchenne paralysis. And this is a paralysis of the shoulder and arm muscles supplied by C5 and C6. Now, what was supplied by C5 and C6? We had the axillary nerve, we had the suprascapular nerve, and we had the musculocutaneous nerve. So whatever muscles that are innervated by these nerves, these muscles are going to get paralyzed. Okay. And the clinical sign is the waiter's tip hand. If you look over here, you can see that the shoulder is adducted, means that it is close to the body. Okay. The arm is medially rotated. So if you have your arm, if you move it inwards, it is medially rotated. So your hand will come out in this position. The elbow is extended. There is no flexion of the elbow. It's straight. And then you have loss of sensation in the lateral upper limb. So over here, in the lateral upper limb, you have loss of sensation. Remember, this was because of the axillary nerve. Okay, we'll come back to that. Now, what muscles are involved? So we talked about how we have combined lesions of the axillary, suprascapular, and musculocutaneous, right? And then we have all these clinical signs. So it's very easy to deduce what muscles could be involved. Now, I'll give you a hint. The hint is a diagram. So we have four of these muscles. We have supraspinatus, we have infraspinatus, subscapularis, and teres minor. And I have the functions here as well. So if we have the arm here, the arm is already adducted. So we have an adducted arm, and we also have a medially rotated arm. Okay, so it's already adducted, it's medially rotated. So which of these muscles is not working? Okay, the answer is supraspinatus. It initiates abduction. So if there's no abduction, then the arm is just adducted. Okay, infraspinatus externally rotates. So the arm in the palsy is medially rotated, which means it is internally rotated. Okay, so that means that the infraspinatus is not working. The subscapularis is working because it causes internal rotation, and our arm is already internally rotated. The teres minor, however, is not working as well because it causes external rotation. Okay, now apart from these, we also had some more signs. We had the extended elbow, and we had loss of sensation, right? So let's talk about those. This is a table, very easy. So you have suprascapular, which supplies the supraspinatus and infraspinatus. The function that is lost is initiation of abduction and external rotation. So as a result, you have the arm which just hangs by the side and it is internally rotated. For the axillary, it supplies the deltoid and the teres minor. Recall that the deltoid does abduction from 15 to 90 degrees and also external rotation, which is from the teres minor. Okay, so weak abduction beyond 15 degrees and the arm hangs. And musculocutaneous supplies the biceps and the brachialis, and the function that is lost is elbow flexion and supination. As a result, in Erb's paralysis or palsy, you have extended elbow and you have a pronated forearm. Okay. One more time, you look here. This is an adducted arm, so adduction. Adducted arm hanging close to the body. It is medially rotated, it's inwards, and also the elbow is straight. There is no flexion of the elbow. Now, moving on. to the lower brachial palsy. It's also called clunky palsy. So this is injury of the lower roots, so C8 to T1 of the inferior trunk. And this is due to the upper limb suddenly being pulled superiorly. So if you have this guy and he's falling down, right? And he suddenly grabs his branch, okay? It is going to cause his arm to be pulled upwards very suddenly, okay? And that is going to cause a brachial palsy of the lower plexus. And also during birth, again, if you have the baby and you pull the arm out, that is going to cause the palsy. And thoracic outlet syndrome is also a cause of clunky. So again, for upper brachial palsy, it was when the angle between the head and the arm was increased. So if you fall from a motorbike, if you fall from the ladder, or if your head is pulled out during delivery. In lower brachial, if you grab onto a branch, or if you have thoracic outlet syndrome, or if your arm is pulled out during delivery. Okay. Now, this is a little bit requires focus. Okay. So we are going to talk about the lumbricals. Lumbricals are muscles in the hand. Okay. These muscles over here. So this red part and this one. So what they do is that they flex the metacarpophalangeal joints. So the knuckles, basically. So when you punch someone, you use your knuckles. And the lumbricals extend the PIP and the DIP. So the proximal interphalangeal joints and the distal interphalangeal joints. So I will just use the abbreviations here. So the lumbricals flex the knuckles and they extend the pip and the dip. Okay. So if your lumbricals are working fine, you can make this gesture. Now, everybody, I want you to take out your hands. Okay. I want you to put them on the table and with your palm facing upwards. Okay. Make sure that all your fingers are like straight, they're extended. Now, what you want to do is bring your fingers straight towards you. So you're going to flex your knuckles. Okay. So this is the position that you're going to have. Now, when you look at this, when you are able to make this C-shaped thingy, that means that your lumbricals are working fine. Okay. However, if the lumbricals are paralyzed, you get a claw hand. Okay, so this is the claw hand, where your knuckles are extended. So if you extend your knuckles instead, this is basically the opposite movement. So extend your knuckles and then flex your pips and dips. Okay, so it is going to look like a claw. And that is what is called a clumkey paralysis or a clumkey claw. Now, this does not include the thumb. It only includes the 4 lumbricals of the 4 fingers because the thumb does not have lumbricals. Okay? Again, all intrinsic muscles of the hand are supplied by C8 and T1. And also, we're going to look at these dermatomes. Okay? If you recall, the medial palm and fingers are supplied by C8. Okay? So you have, this is the medial palm, and you have the medial fingers. These are supplied by C8s. And medial forearm plus arm if T1 also involved. So if you have the forearm and a little bit of the arm, that means that T1 is also involved in the brachial palsy. So sign is complete claw hand, 4 fingers except thumb due to paralysis of all 4 lumbricals at rest. Now, if you see a claw hand, you're not asking them to make the claw hand, okay? It's at rest. So if a patient comes to the ER or whatever, he comes to the exam room and you see that his hand is already clawed, you're not asking him to do anything. That is a sign of lower brachial palsy. Okay. And if T1 is involved, you're going to have Horner syndrome and the T1 sympathetic pathways. And that is going to have 3 major signs. You have ptosis, which is drooping eyelids. You have miosis, which is constricting pupils. And you have anhidrosis, which is loss of face sweating. This is Horner syndrome. So we can see here that the upper eyelid is it's going down. It's drooping. We have the pupil, which is like sort of constricted. It's pinpoints. And then the eye is bloodshot and there is lack of sweating. So there's no sweating on the face anywhere. Okay, it's dry. Now you might ask, okay, why is the eye red? Okay, this is because you have loss of sympathetic pathway. Okay, T1 loss of sympathetic pathway. And what that means is that you get vasodilation of the conjunctival blood vessels. So you have these blood vessels in the eye, okay, and they're vasodilating, they're vasoconstricting, whatnot. Vasoconstriction needs muscles. If those muscles are paralyzed because of a T1 Horner syndrome, they're going to get dilated and you're going to see that redness appear on the conjunctiva. It's not important, but just to explain it over here. Now, let's talk about the winged scapula. This is a very, very frequently asked question, by the way. So this is due to radial mastectomy or trauma to lateral chest. Mastectomy is when you remove the whole breast, mainly because of breast cancer, or you could have trauma to the lateral chest. Okay, so if you stab someone here like that, you're going to damage the long thoracic nerve. Okay, recall that this was a branch from C5, C6, and C7 roots. Now, what the long thoracic nerve does is that it supplies the serratus anterior. Okay, the serratus anterior is what's going to hold the scapula against the back. Okay, so when you don't have that innervation, when your serratus anterior itself is paralyzed, okay, you're going to have the medial border of the scapula moving laterally and posteriorly away from the thoracic wall. Okay, and that is going to give you an appearance of a wing. Okay, so I want to show you here. If you look here, this is the scapula. Okay, this is the medial border of the scapula. Now, if this part is not being held properly because of paralysis of serratus anterior, it is going to move outwards and laterally. So it's going to give you this appearance. Okay. And also, this wing is prominent when doing push-ups or wall push-ups. If you ask somebody to lean against the wall and do a push-up, you're going to see that the wing is very prominent. And if the serratus anterior is paralyzed, you also have another sign that the arm cannot be abducted over the horizontal. So if you ask a patient to abduct his arm over 90 degrees, he cannot do it because the serratus anterior is paralyzed. Okay? Yeah, so this is the long thoracic nerve going down. Now, moving on. Injury to the suprascapular nerve. Now, recall, where was the suprascapular nerve coming from? Give yourself like some time to think about it. Okay, so it was coming from C5 and C6. So basically, when you had the C5 and C6, it made the superior trunk, right? And it was coming out from the superior trunk. So it has innervation from C5 and C6. Okay. Now, we're going to look at the course of the suprascapular nerve and see that if we have injury at different points, how would that affect our muscles and in turn the function of the muscles. Okay. So we talk about the suprascapular notch and the transverse scapular ligaments. Now, if you look here in this picture, it's very clear. You have this notch, it's going down, right? And then you have this ligaments. Now, these two things joined together, you can see like an opening. This opening is called the suprascapular foramen, okay? And then down here, after that foramen, so this is the suprascapular foramen, right? And then over here, you have the spinoglenoid notch and the spinoglenoid ligaments, okay? So this is the notch and this is the ligaments. Again, you have like sort of another foramen. So the suprascapular nerve is going down. It's going down. It goes through the suprascapular foramen, okay? And then it gives off branches to this muscle. What is this muscle? This is the supraspinatus, okay? And then after giving off branches to the supraspinatus, this suprascapular nerve is going to go down, down, down through this spinoglenoid notch thing. It's going down, and then it gives branches to this big muscle. What is this muscle? This is the infraspinatus muscle. Okay, I don't think anybody can read that, but this is infraspinatus. Okay. So now we will talk about the injuries. So if you have an injury over here, okay, that means that you are compromising branches to the supraspinatus, and you are also compromising branches to the infraspinatus. So you're cutting off the nerve here. That means that your supraspinatus and your infraspinatus will stop working. So this is two muscles that will not work. Okay? And then if you have an injury at the second location, which is the location of the spinal glenoid notch, so over here somewhere, if you have a lesion here, you're only going to affect the infraspinatus. So that's only one muscle. Because before going through the spinal glenoid notch, it has already given branches to the supraspinatus. So it will not be affected if the lesion is more downstream. Okay, I hope this is clear. Whoa. Okay, this is in text. So, injury at suprascapular foramen equals to both supraspinatus and infraspinatus muscles affected. Injury at the spinal glenoid notch is only infraspinatus affected. Now let's look at the functions. The supraspinatus initiates abduction from 0 to 15 degrees. So if you have somebody standing and their arm is by their side, and if you want them to move their arm away, abduction, so 0 to 15 degrees is supraspinatus. And then infraspinatus is basically externally rotating the arm. So if you have an arm and you want to move it externally rotated, that is infraspinatus. I hope that this is clear. Okay. Now we move on to, oh, another picture. Okay. This is a brachial plexus again. We can see that. Just a little reminder that it's out there. Okay. Now we move on to the subscapular nerves. Now recall, where did we find these subscapular nerves? Okay, it's down there. You had the posterior cord, right? Like that. And then you had three branches. So 1, 2, and 3. Number 1 was the superior subscapular nerve. Number 2 was the middle subscapular nerve. And the third one was the inferior subscapular nerve. Now, the superior one supplies the subscapularis, the middle one supplies the latissimus dorsi, and the inferior one supplies the subscapularis and the teres major. Teres major, however you want to pronounce it, but yeah. Okay, so the subscapularis and the teres major are going to medially rotate the arm. The latissimus dorsi is going to adduct, adduction. It's going to add the arm to the body. It's going to extend and medially rotate the arm. Okay? That's like the three muscles mentioned here, by the way. So injury to the superior and inferior subscapular nerves. So if you damage, okay, let me just clear this out again. It's a lot of time. There should be like an efficient way to do this. But let's do that. Okay. Now, if you have an injury to the superior and inferior subscapular nerves, so this one and this one, you're going to damage the subscapularis. You're going to de-innervate the subscapularis and you're going to de-innervate the teres major. Okay, so that's two muscles. So you're going to have weakness in medially rotating the arm. Then you have the latissimus dorsi. Okay. Injury to the medial or the thoracodorsal nerve impedes walking with crutches due to weakness in adduction, extension, and medial rotation of arm. Now, I forgot to add a picture, but basically, if you see somebody walking with crutches, you need to be able to hold the crutches closer to your body, right? And that requires adduction of the arm. So if that is not working, you can't hold the crutches properly. And it also requires extension of the arm to move forward with the crutches, okay? And also medial rotation to hold the crutches. So basically, if you damage this middle thoracodorsal nerve, your latissimus dorsi will not work and you won't be able to walk with crutches. Okay, so this is this huge muscle here. This is latissimus dorsi supplied by the thoracodorsal nerve. You can see here. You have this huge long nerve coming down. Should use another color actually. Okay, green. So you have this huge long nerve coming down. This is the thoracodorsal nerve. Okay. Then we talk about injury to the musculocutaneous. This is the simplest one that there will ever be. So I tried adding some jokes to the slides, but this lecture is nothing to joke about, so it's like whatever. Let's lock in. So we have injury to musculocutaneous. Okay, so musculocutaneous arises from the lateral cord. It was like that. Now it supplies the coracobrachialis, it supplies the biceps brachii, it supplies the brachialis, and then it goes on to give the lateral cutaneous nerve of the forearm, which supplies the lateral forearm over here, sensory. Okay. Now suppose somebody has been stabbed here over the lateral arm, for example. Okay. That is going to cause weakness in flexion. Now, why would there be weakness in flexion and not just loss of flexion? This is because you have brachyradialis. Brachyradialis also um, has some sort of flexion. Okay, it also helps in flexion. And then you would also have weakness in supination. But however, this is not paralysis because supination is still possible because of the supinator. Recall that the brachyradialis and the supinator are both supplied by the radial nerve. Okay, so most of you are already starting to think, wait a second, radial nerve? We'll come back to that. So again, injury to musculocutaneous, weakness in flexion, weakness in supination, and also anesthesia over lateral forearm. Okay, now hold up. Doesn't the radial nerve only supply extensors? What is it doing supplying the weak? Why is there weakness in flexion? Because the brachyradialis is helping with flexion. Why is that? Because the radial nerve is only supposed to supply the extensors, right? Why is it supplying the brachyradialis? So let's think about that. The answer is here. The brachyradialis is a posterior muscle in disguise. It may be innervated by the radial nerve, but it flexes the elbow and lies more laterally in the posterior compartment. So basically what that does, this muscle will flex the elbow, okay? It will flex the elbow, but it is innervated by the radial nerve, okay? So moving on, we have the fractures. Okay, so a surgical neck fracture. So you guys recall that we had the humerus, we had it going something like that. Okay. Now, if you cut off the neck over here, if you fracture the neck, that is going to damage the axillary nerve. Okay. So if the axillary nerve is damaged, C5 to C6, the supply to the deltoid and the teres minor will be cut off. Okay. Now recall the function of the deltoid was to abduct the shoulder. Abduction is moving your arm away from your body, so abduction. So those 15 to 90 degrees, the patient will not be able to do. So if you look over here, if surgical neck fracture of humerus or posterior dislocation of shoulder joints, then you have an inability to abduct shoulder beyond the first few degrees. Okay, so first few degrees, okay, the supraspinatus is already doing that. After those first few degrees, you can't seem to abduct your arm. This is because your deltoid is paralyzed. And also you have flattening of the shoulder contour. So basically your shoulder looks like sort of flatter because the deltoid is atrophies. Okay. Sensory loss over deltoid upper lateral arm. If you recall, axillary also supplied sensory to the lateral upper arms of this area. Okay. That is why you have sensory loss over the deltoid. Recall, axillary nerve is from the posterior cord. Okay. So I hope that this part is clear. If not, please watch it again because this is very important. By the way, the doctor said that this lecture is heavier than the lower limb injuries, lower limb nerve injuries, and so there will be more questions from this. That is why you have to make sure that you know everything properly. Okay, review. So basically, I talked about how deltoid abducts the shoulder from 15 to 90 degrees, right? What about the rest of the degrees? This is the review. So the supraspinatus is going to initiate abduction from 0 to 15 degrees, and then 15 degrees to 90 degrees, which is the horizontal. And then the serratus anterior and the trapezius above 90 degrees. Okay. Now, we have very important slides coming up and possibly very cramped slides because there's a lot of information. But there's a process to doing all of this. So let's look at that. We are going to talk about the radial nerve injury, we're going to talk about the median nerve injury, and we're going to talk about the ulnar nerve injury. We'll use red. Okay. Now, radial nerve injury can be caused by a mid-shaft humeral fracture or by an injury to the anatomical snuff box. Okay. Median nerve injury is caused by a supracondylar fracture or carpal tunnel syndrome. And then the ulnar nerve injury is caused by a medial epicondyle fracture or a hamate fracture. Okay, so if you don't take anything from this whole part, just take like just this. This slide is very important. Okay, so moving on. Radial nerve midshaft fracture. So you have the humerus, and then you cut it from the middle. That's a fracture. That is going to cause the radial nerve to be damaged. Now, recall that the radial nerve supplies the extensors of the arm and the forearm. So of the arm, you have the triceps, so and this one, and this one. And you also have the anconeus, okay? So it supplies those two muscles. And then it also supplies the extensors of the forearm, so all of these, right? So let's go continue reading. So it supplies triceps above the fracture and elbow extension is spared. So basically the fracture is occurring here in the mid shafts. The triceps have already been supplied. So if you cut the nerve from here, everything downstream will be paralyzed, not upstream. So the radial nerve in the spiral groove is injured and you have loss of wrist extension, which means you have wrist drop as seen over here. So the patient tries to flex their what was it? If they try to flex their wrist, if they try to extend their wrist, this is a little bit confusing. If they try to extend their wrist, it won't be possible because you have loss of extension. So your wrist is just going to drop back down like that. Okay. And you also have loss of extension of fingers. And sensory loss on posterior forearm and hand. So as you can see here, the radial nerve is supplying this area. Okay. So from here, 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 and here, and then this whole dorsum is supplied by the radial nerve. Loss of extension of fingers, so let's go look at that. Now, if you look here, you have the brachioradialis, you have the extensors, extensor, you have the supinator, you have extensor, digitorum, digiti minimi, carpi ulnaris, pollicis, indicis. So all the finger extensors are also going to be paralyzed if you cut off the humerus from here, okay? And the test, of course, we just talked about this, for midshaft fracture and injury to the radial nerve is the wrist drop. Moving on to the radial nerve damage in the anatomical snuff box. Why is it called the anatomical snuff box? Well, if you look over here, basically, people like used to put stuff or like sort of substances into their anatomical snuff box and like to snuff that out, right? So that's why it's called the snuff box. Anyways, recall that the deep branch to the extensors of the forearm is unaffected here, okay? Because if we go down here, look at this diagram. Now, see, we are putting this part, this is the injured part, okay? The deep branch is already supplying all of the forearm extensors over here, right? It's already supplying. However, the superficial branch is going to go down and that will be affected here. So you look up and you see that the deep branch to the extensors of the forearm is unaffected. That means your extension of the wrist is fine. That's working. Okay. In fact, your extension of the fingers is also working. Like all the motor is working. So your motor extension is not going to be affected if you have an injury to the anatomical snuff box. However, your superficial branch, which is sensory, will be affected. So you have sensory loss on the posterior hand. So if you take the hand, you take the dorsum of the hand, you're going to have sensory loss in this coin-shaped area between the first and second metacarpals. So 1, 2. So between these two areas, you have a coin-shaped area, which is where you have sensory loss. Okay. Now let's look at the radial nerve course again. Note the location of the superficial and deep branches. Okay. And it divides into these two branches at the level of the lateral epicondyle. It's not important, but anyways, just look here again. So if you cut off the radial nerve from here, everything below is going to be paralyzed. All these muscles are going to be paralyzed, right? You're also going to have superficial loss because the superficial branch is ultimately coming from this huge nerve, right? However, if you cut it off from this snuff box, the deep branch here is unaffected. So the extension is working fine for the fingers and the wrist and the forearm, but the sensory loss is present. Okay. Let's move on to the median nerve. Supracondylar fracture. Now, if you recall, if this is the humerus, the supracondylar area is just above the condyles. So like over here. Okay. Cut it off over here, you're going to lose function of all of these muscles. Now, recall that the median nerve is motor to forearm flexors, except for two. And recall that the recurrent branch to thenar and lumbricals 1 and 2 is by the median nerve. And recall that the palmar cutaneous branch to the lateral palm are 3.5 digits. So what that means basically is that motor to forearm flexors. So all these flexors, you see pronator teres, you see flexor carpi radialis, you see palmaris, you see flexor, pronator, and then all these thumb muscles as well. Okay, and the first and second lumbricals are supplied by the median nerve. And then you have palmar cutaneous branch to the lateral palm. So if you take the palm here, take out your palm, you see that the thumb, you see the index, you see the middle finger, and you see like a little bit of the ring finger are supplied by the median nerve. And also this area over here. Now, when you have a supracondylar fracture, you're basically cutting off the source of the nerve. You're cutting it at the very top, at the proximal area. So you're going to have proximal signs and you're also going to have distal signs because you're cutting off innervation here and you're also cutting off innervation here because you're cutting at the top. So proximal signs, weakened wrist flexion and ulnar deviation upon flexion due to paralysis of flexor carpi radialis. Now what this means is that the median nerve supplies the flexor carpi radialis. The function of the flexor carpi radialis is to flex the wrist and also to move it towards the radial side. Okay, so upon flexion, your hand can either move to the radial side or it can move to the ulnar side or it can stay in the middle depending on the lesion. So let's look at this part here. Note, ulnar deviation is caused by flexor carpi ulnaris, which is by the ulnar nerve. So if you have ulnar deviation, that means you move your hand to the left towards the ulna. Okay. That is called ulnar deviation and is caused by flexor carpi ulnaris. Radial deviation, moving to the radial side, is caused by flexor carpi radialis, which is supplied by the median nerve. Both of these muscles flex the wrist, but also cause their respective deviations. So if you have loss of radialis, the hand is automatically going to move to the ulnar side. And then you have complete loss of pronation. This is because your pronator teres over here and your pronator quadratus over here are both paralyzed. So you don't have pronation. And then you have loss of flexion of lateral 3 digits. So inability to make a complete fist when asked to. This is a benediction hand. So basically, if you have a person, okay, and you ask them to hold up their hand, and then you ask them to make a fist, they won't be able to make a complete fist. Okay, this is what you're going to see. You're going to see this hand over here. You're going to see that the ring finger and the pinky finger are flexing fine. They're going into making the wrist. However, the index finger and the middle finger and the thumb are straight. They're not able to flex these fingers. Okay, this is benediction hands. Now, there wasn't any detail on benediction hands in the slides. However, I will give you the details just for your knowledge. Okay. And hopefully that makes sense as well. So the benediction hand is caused by the median nerve injury, right? And the patient can't flex the thumb, he can't flex the index, and he can't flex the middle finger. This is because you have paralysis of the flexor digitorum profundus, just the lateral half, and then you have paralysis of the flexor digitorum superficialis. Okay, so you have paralysis of 2 muscles that we can see here. So flexor digitorum superficialis and also the radial part of the flexor digitorum profundus. These muscles are involved in making the fist. Okay? That is why you have benediction hands. Distal signs, you have loss of thumb opposition, you have ape hands. So basically, as you can see here, the median nerve supplies this muscle here, the opponens pollicis. Opponens pollicis is what's going to cause the opposition of the thumb. Now, if you paralyze that muscle, you won't be able to do opposition. So you're going to get an ape hand. Sensory loss on lateral palm and 3.5 digits. You just talked about that. Moving on. This is the deviations. Okay. Then we have the carpal tunnel syndrome. Now, what is this? Recall that the median nerve supplies the thenar 1 and 2 lumbricals. Okay. And it also supplies the opponens pollicis and the palmar cutaneous branch of the lateral palm. Right? And in this case, when you are only compressing it distally, you're only compressing the nerve distally, you're only going to have distal signs because the carpal tunnel is over here. Okay, so it's distal, it's towards the hand. So the opposition of the thumb is lost. So your opponens pollicis is not working. So you're going to have an ape hand at rest. And you're going to have sensory loss on lateral palm and 3.5 digits, just as mentioned before. And the test for this carpal tunnel syndrome and injury of the median nerve is that the patient cannot hold a piece of paper between the thumb and another finger. Okay. Now, because opposition is lost, the thumb can't move towards the finger, and so they can't hold the paper between their thumb and another finger. Okay. Yeah, this is the ape hand. So basically, apes can't oppose because they don't have rights. Forget that part. Apes can't oppose. So ape hand cannot do opposition. Why? Because the opponens pollicis again is paralyzed, and also the thumb muscles, the thenar muscles, which are supplied by the median nerve, are undergoing atrophy. So you have thenar eminence wasting. So it's going to become like a very, very small area. It's going to become very flat as well. So it's going to look something like an ape's hand. I hope that it's clear so far. This was a lot to take in. So just want to go over it one more time. So the radial nerve, mid-shaft fracture, right? Radial nerve supplies the extensors of the arm and the forearm. And then the radial nerve is associated with anatomical snuff box damage. And that is only superficial. The branch is only superficial. So you only have sensory loss. Okay. Again, radial nerve course, you can see here, this is the deep branch and this is a superficial branch. Deep branch is not affected in the anatomical snuff box location. So only the superficial, so only the sensory loss is present. Then you have the median nerve. You break the humerus at the level of the supracondyle, so basically above the condyles, and you're going to get a median nerve injury. Okay, you're going to have proximal signs and you're going to have distal signs. Proximal signs because the median nerve supplies the flexors. Okay, so you're going to have weakened flexion of the wrist and also loss of pronation and benediction hands. Distal signs, loss of opposition. So you're going to get ape hand, especially with carpal tunnel syndrome. Okay. Now we move on to the ulnar nerve. So let's take a little breather. Okay. So the ulnar nerve, we recall, supplies two flexors. We have flexor carpi ulnaris, and we have the medial half of flexor digitorum profundus. Okay. The median nerve before supplied all the flexors. It was supplying every single flexor there was in the forearm. However, it did not supply these two flexors, the flexor carpi ulnaris and the medial half of the flexor digitorum profundus. And these are now supplied by the ulnar nerve. Okay. Recall that it also gives a cutaneous branch to the medial 1.5 fingers. So if you look over here, you have sensory innervation to the medial 1.5 fingers on both sides of the hand. So this is the palmar side, and this is the dorsal side. Okay, so the palmar side over here, this is the pinky, this is half of the ring finger. So 1.5 sensory innervation. Again, pinky and half of ring finger, so 1.5 sensory innervation. Okay, and also The deep branches are to the hypothenar, interossi, and lumbricals 3 and 4. So we can see here the deep branch goes up to the hypothenar, and it goes to the interossi, and also goes to the lumbricals 3 and 4. So the lumbricals of the pinky and lumbricals of the ring. Now, when you have a medial epicondylar fracture, so this nerve is going along very peacefully, okay, and then you have a fracture here, boom, okay? Everything is going to be paralyzed. Everything is going to lose function because you see here, you have proximal signs. Proximally, it is supplying these two flexors, right? So this will be paralyzed. This will be paralyzed, okay? Down here, the hypothenar muscles are paralyzed. The interossi are paralyzed. And the third and fourth lumbricals are also paralyzed, okay? So proximal signs, we're going to get weakened wrist flexion and radial deviation upon flexion, because recall that wrist flexion is by the flexors, right? And also, when you lose the carpi ulnaris, you're going to have radial deviation. So your hand is going to move in the side of the muscle that is working. So if the carpi ulnaris is not working, it will not move towards the ulnar side. Inability to flex dip of 4 and 5th digits. This is relatively straightforward because the flexor digitorum profundus. So FDP is what supplies the dip. Okay. Again, this is only the ulnar portion. So the ulnar portion only supplies the 4th and the 5th digits. So if this ulnar portion of this FDP is paralyzed, you won't be able to flex the distal interpharyngeal joints of these 4 and 5 digits. Okay, so that is lost. And then you have the distal signs. Let me clear this up. It's a little messy again. Now the distal signs. Paralysis and atrophy of hypothenar and third and fourth lumbricals. Now you can see distally, the hand is distal. Okay, this is proximal. So distally, you can see that the hypothenar muscles are affected, the interossi are affected, and the lumbricals are also affected. So paralysis and atrophy of hypothenar and third and fourth lumbricals. So the flexion at knuckles is lost. We will come back to this. Paralysis of interossi, so no PAD and no DAB. So no palmar interosseous, no adduction of the fingers, and no abduction of the fingers because of the interossi paralysis. And then you have sensory loss of 1.5 fingers. We just talked about this. You lose sensory innervation over here and over here. And then the sign for this medial epicondylar fracture is claw hand of the 4th and 5th digits at rest. Okay. Now, if you have a patient, he comes to the emergency room or he comes to the exam room, and you see that his hand is fine, but his 4th and 5th digits are kind of clawing. You can see them clawing a little bit, and it's at rest. You're not asking him to do anything. That means that you're dealing with a lesion of the ulnar nerve. Okay, and if you ask him to do opposition of his thumb, it's still possible. Okay, that just further confirms that you're dealing with the ulnar nerve. Okay. Now, don't forget that the medial epicondylar fracture will lead to a claw hand, now a partial claw hand that looks like this. Okay. Then we move on to the hamate bone fracture. So we're almost done. So stay locked in. Almost done. We have Guyon's. I don't know. I'm not sure how to pronounce this, but Guyon's canal syndrome. Okay, where the ulnar nerve is compressed. And usually this happens because of repetitive movements. Okay, you have like cyclists when they hold like the handle of the bar, they're prone to get this canal syndrome. Okay, or it could also be due to a ganglion cyst. It could also be fracture of the hook of the hamate. See over here, you have the hand, and this is a medial side. We're holding the hammer, for example. This thing is going to get fractured. So that is what's going to cause the ulnar lesion. So recall that the ulnar supplies flexor carpi ulnaris and the medial half of the flexor digitorum profundus. Okay. Recall that it also supplies a deep branch to the hypothenar and lumbricals 3 and 4, and recall that it supplies the cutaneous branches to medial 1.5 digits. So we are not concerned with this part here. Okay, we already talked about how we have paralysis of the ulnaris and the medial half, blah, blah, blah. We talked about this over here and the epicondylar fracture. But now in the hamate fracture, we're not concerned with that because the lesion is way below that level. Now it is at the level of the hypothenar and lumbricals and the cutaneous branch. So you only have distal signs. Okay? You have paralysis of the hypothenar and you have paralysis of the lumbricals 3 and 4. And also paralysis of the interossei. So your palmar interosseous muscles cannot do adduction and your dorsal interosseous muscles cannot do abduction. So both of those are lost. You have sensory loss in 1.5 digits, medially, of course. And then claw hand, again, this is the same sign again. Claw hand. Clawing of the fourth and fifth fingers due to paralysis of the lumbricals. Opposition of thumb is still possible. Again, patient comes to you, his hand is already clawing naturally at rest, and opposition is still possible. You immediately go for ulnar nerve, claw hand. Okay? Now you want to test if this claw hand is because of the medial epicondylar fracture or it's because of the hamate bone fracture. Okay. That is not in the slides, by the way. Okay, never mind. I won't say it. It's not in the slides. Okay. So you have test. A patient cannot hold a piece of paper between index and middle fingers. That gives you interosseous paralysis and no adduction of fingers. Okay. So since we have paralysis of the interosseous, so no pad, no dab. Okay. So in order to hold a piece of paper between the fingers, you have to bring your fingers closer together, right? To hold the paper. So the patient will not be able to bring his fingers closer together because of the fact that his interossei are paralyzed. So he cannot hold this piece of paper. He cannot do this. Okay. Now this is sort of an important slide. Now, if you look here, we have the metacarpophalangeal joints, so the MCP joints. Then you have the PIP joints, and then you have the DIP joints. Okay. At the MCP, your lumbricals are what perform flexion. Okay. So your knuckles, if you want to flex your knuckles like that, that is performed by the lumbricals. And extension is by extensor digitorum. At this part, PIP, if you want to flex, you're going to use your flexor digitorum superficialis and profundus. And if you want to extend those PIPs, you're going to use, again, the lumbricals. And then at DIP, if you want to flex your distal interphalangeal joints, you're going to use flexor digitorum profundus only, not superficialis. Okay? And if you want to extend those, you use lumbricals. So basically, the summary here is for MCP, if you want to flex, you're going to use lumbricals. Okay? And for PIP and for DIP. Okay, so I'm writing them down here. For PIP and DIP, if you want to extend, you have to use the lumbricals. So there's two functions that I want to focus on. So the lumbricals are going to flex the MCPs and they are going to extend the PIP and the DIP. Okay? Same thing in text. So the lumbricals flex the knuckles and extend the PIP and DIP. Simple. The flexor digitorum superficialis flexes the MCP and the PIP. Profundus flexes the MCP, PIP, and DIP. And extensor digitorum extends the knuckles. Okay. So in case of a claw hand, I want to find out, okay, why does this person have a claw hand at rest? What's going on? Because at rest, you're supposed to have like a hand that is like, it's not clawing or it's not extending or anything. It's just like a normal hand, right? So what is it? What is the cause of that clawing? Basically, it's due to the imbalance between the forces of the muscles because some of them are paralyzed. Let me explain that. So you take blue. Okay. So in claw hand, the MCP is extended. Why is it extended? So the knuckles are extended because of unopposed action of the extensor digitorum. The lumbricals of the pinky and ring fingers are not working to flex the MCP. So the MCP, the job of the lumbricals is to flex the knuckles. If those lumbricals are not working, then your knuckles will stay extended because of the unopposed action of the extensor digitorum. Okay? Now your PIP and DIPs are flexed due to the unopposed action of flexor superficialis and profundus. So the lumbricals are not working to extend the PIP and DIP. So basically, your PIP and DIPs are basically flexed. Okay, so those little joints, all your fingers, they look like a claw because they're flexed. And the lumbrical's job is to extend them back to the normal position, right? But those are paralyzed. So that means that you have so you have extended knuckles and flexed PIPs and DIPs. Okay, I hope that made sense because I got a little bit confused there too. So if you have the hand, okay, the MCPs, so 1, 2, 3, and 4. Okay, so there are 4 lumbricals. And all 4 of them are paralyzed in the case of Klumpke paralysis. Okay, so the claw hand is complete. However, in the case of an ulnar nerve injury, only the lumbricals of only the third and fourth lumbricals are paralyzed. So the fourth and fifth fingers are not working. So your ring finger and your pinky finger will not work properly. They'll claw into a hand, they'll just claw, basically. So, your MCP over here, in the case of a clawed hand, it's going to be extended, okay? And your PIP and DIP, so this one, so these 2 PIPs and these 2 DIPs are going to remain flexed, okay? So flexion and flexion, and that is how you will get the claw hand. I hope that is clear. Okay, so benediction hand versus claw hand. Now, if you look at this hand over here, this is a sort of a religious gesture, but it looks very similar to a benediction hand. So that's why I put the picture here. A benediction hand occurs when you are asked to make a fist. It does not occur at rest. So the thumb, index, and middle fingers are unable to flex. The ring and pinky flex normally. So if you ask a patient to make a fist, his ring finger and his pinky finger will flex normally. However, his index finger and his middle finger and his thumb will remain extended. Okay, now we talk about claw hand. Claw hand happens at rest. Okay, in Klumpke, all 4 lumbricals are paralyzed. All fingers are in a claw. Okay, but claw hand in the ulnar nerve injury is only just this ring finger and this pinky finger. Okay, and this is also at rest. So both of the claw hands are at rest. There's a problem with the lumbricals of the ring and pinky since their job is to flex the MCPs, but here the knuckles are extended. The DIP and PIP are flexed due to the unopposed action of flexor superficialis and profundus when the lumbricals should extend them. Okay. So yeah, that's pretty much it for this. Upper limb injuries. So I just want to look at it one more time. So radial nerve was mid-shaft humeral fracture and anatomical snap box. Median nerve injury was supracondylar fracture and carpal tunnel syndrome. Ulnar nerve injury was medial epicondyle and hamate fracture. Okay. Radial nerve, you will see a wrist drop. Okay. Again, radial nerve, you will see sensory loss of this coin-shaped area. Median nerve, supracondylar fracture, you will see a benediction hand. Median nerve, carpal tunnel syndrome, you will see an ape hand at rest. And then ulnar nerve, medial epicondylar fracture, you're going to see a claw hand of the ring finger and the pinky finger. And also you will see for the hamate bone fracture, same thing, claw hand. And the patient cannot hold a piece of paper between both of their, any of their fingers. So this function over here, this is lost. This was just explanation. Okay, now it's time for questions. So you can just pause it and then answer and then move on. So question, which nerve lesion causes a benediction hand? The answer is the median nerve due to a supracondylar fracture. More questions. So what happens if the hamate is fractured? Now the hamate recall is medially located, so that's a hint. So if the hamate is fractured, you're gonna get, what are you gonna get? You're gonna get a benediction hand, you're gonna get a claw hand, you're gonna get an ape hand, or like a mixture of claw and ape. So the answer here is going to be claw and ape hands. Okay. Now, what forearm flexors does the median nerve not supply? Is it A, B, C, or D? Okay, so we'll move on to the answer of this. The answer is C. Half of flexor digitorum profundus and flexor carpi ulnaris. And why is that? Both of them should be the answer. So the median nerve does not supply the supinator, and it does not supply the flexor carpi radialis. Okay. The median nerve also does not supply, okay, wait, hold on, I made an error. The median nerve does not supply the supinator, but it supplies the flexor carpi radialis, okay? The median nerve supplies the flexor pollicis longus, but it does not supply the flexor carpi ulnaris, okay? Now, the median nerve does not supply the half of flexor digitorum profundus and flexor carpi ulnaris, okay? So it doesn't do that. So that is why C is the right answer. Now, the median nerve supplies sorry. Okay. Yeah. Just looked that up. I got a little bit confused. Open up the brachial plexus again. See, now this is very, very confusing. And it's okay to be confused because I tried to make this question as confusing as possible and then I got confused myself. So let's pull out the little median nerve. Okay, so the median nerve supplies the palmaris longus. Okay, yes, it supplies the palmaris longus and half of flexor digitorum profundus. Okay, so yeah, it supplies that too. Okay. This question is a little bit confusing. I suggest that you go over the muscles one more time. It might not make sense because right now I can't seem to get what's going on here. So please look into this. However, the answer for this question is claw hands. Okay. Now, moving on, we have the SMART chart from Dr. Vlad's lectures. We have the axillary nerve, we have the musculocutaneous, and then we have the radial, median, ulnar, long thoracic, and suprascapular. Okay, so these are the clinical signs, just a little table that you can go over. And this is the QR code. If this session helped you or if it did not, whatever feedback you have, please scan this. And that's pretty much it. Thank you. If there's any questions, please, again, you are free to email or text me on my number. And good luck for your exam. A piece of advice is that if you're going through, for example, the lectures and you're getting confused and you don't know what to do, what you need is just like a little bit more time, okay? Because these things do not sit in your brain just like automatically. You have to give time to the lectures, you have to give time to all the nerves. And very naturally, it took me like a lot of time to prepare for this PAL session, and I still got confused with this last question. So that's okay. And if don't freak out and just give it some time, okay? And best of luck. Thank you.